Good morning, everyone. Welcome to the last Katz Institute Grand Rounds for this academic year, the school year, and thank you very much for joining us as you get on. Rosanna, next slide, please. As you know, the Katz Institute is focused on improving health outcomes for women by looking at a complete healthcare connection through clinical partnerships, education, and research. Next slide. Our pillars are here for you. Clinical programs that are extensively focused on a woman at the center, not along our service lines or academic departments. Continuing medical education, so amongst us, we can learn from each other. We know that women experience healthcare differently, and we're focused on that. Community partnerships is clearly important to us, with about 35,000 individuals regularly tuning into our newsletters and to our other assets. Focusing on going upstream with medical education and researches that compensates for years of inequities. And clearly, we'd like Katz to be the trusted voice for those in our community and for each of us as clinicians and investigators. Thank you, as always, to our friends Mary and Richard Slone for their generous support of the program. The Slones have been longtime supporters of Northwell and of women's health in general. And through these grand rounds, they have committed to us the opportunity to educate and advance scientific education. Just a bit of housekeeping. CME credits for today's grand rounds are available. We are jointly accredited by the ACCME, ACPE, and ANCC to provide continuing education for healthcare professionals. And at the end of today's program, we'll share a link so that you can complete your evaluation and claim credit. As a reminder, please, you have only 48 hours to claim credit. The following is a disclosure policy. We adhere to the standards for integrity and independence in accrediting continuing education. All planners and speakers for today's program have nothing to disclose. Please submit your questions to us using the Q&A feature in the webinar. We'll have a moderated panel with Q&A following. It is now September 30th, the start of next academic year with Dr. Wanda Nicholson from the USPSTF and the Milken Institute School of Public Health. It's now my distinct privilege to introduce to you all today's speaker, Dr. Kevin Volpp. Kevin is the founding director of the Penn Center for Health Incentives and Behavioral Economics and the Mark V. Pauly President's Distinguished Professor at the Perelman School of Medicine and the Wharton School of the University of Pennsylvania. He has led CHIBE from its start as one of two original NIH centers on behavioral economics and health to a center which has inspired the creation of dozens of programs in behavioral economics and health nationally. Dr. Volpp's work focuses on developing and testing innovative ways of applying insights from behavioral economics and improving patient health behavior and increasing health system value by influencing clinician performance. He oversaw the creation of the first health system nudge unit at Penn Med and is the scientific lead of the American Heart Association Health Care by Food Initiative, a national research initiative designed to build evidence on effectiveness and cost-effectiveness of programs to improve health through increased access to nutritious food. Dr. Volpp's work has been recognized by the NIH Matilda White Riley Award, the AHA's Distinguished Scientist Award, along with many, many other prestigious awards, numerous Article of the Year awards as well. It's now my great pleasure to introduce and welcome you, Kevin. Thank you. The floor is yours.
Thank you so much, Stacy. It's nice to be here. I'm having trouble. Oh, there we go. So here are my disclosures. And I want to start here. The US is first in healthcare spending and 48th in life expectancy. And we rank last on a number of key healthcare measures compared with countries with which we're compared with. This really highlights we need to find more cost-effective ways to improve health. Behavior can be thought of as the final common pathway in improving health, whether we're talking about what clinicians do or what patients do. There are many statistics that highlight that. One is that only about 40 to 45% of patients in the year following a heart attack take all their recommended medications. And this is because much of what we do are what Lewis Thomas once called halfway technologies. They don't eliminate disease. In essence, we're managing chronic conditions, and clinicians need to recognize and initiate treatment, and patients then need to adhere to those treatments and modify their behavior as needed. Part of why this is important is we used to think about people as being perfectly rational, that if we just give them information, they'd automatically, in their minds, calculate the expected probabilities, the outcomes, and through a process of backwards induction, figure out which choice path has the highest net present value. If that were true, all we need to do is give people information, adjust prices, and we don't worry about things like the complexity of interventions because the brain has infinite capacity to make these decisions in a carefully considered way. However, behavioral economists have highlighted that people systematically make a number of decision errors. There's status quo bias, where we tend to continue our current behaviors even if better alternatives exist. We tend to heavily overweight immediate gratification, which is why present bias preferences are so important. We tend to overweight losses relative to foregone gains. We overestimate small probabilities near zero. We tend to think of money as being in separate accounts, although in reality it's really fungible. And an important principle is this notion of limited bandwidth, where people can't reflect deeply on each decisions. And this is true whether you're a busy clinician or you're a patient living in a challenging environment. If you're making hundreds of decisions a day, it's very hard to think through each one as carefully as you might if you had very few decisions to make. So in designing programs, we tend to think of the mind as something akin to a high resistance pathway. So in addition to trying to carefully consider each decision, it's a little bit like the patellar reflex of the knee, where we think about these behavioral reflexes, which in essence bypass cognition. And so information alone is not enough. We tend to think about the importance of the environment in which people make choices, the choice architecture, and the role of default. Incentives, we tend to take more of a behavioral lens, and I'll explain more about that momentarily. And we need to account for complexity because people do have limited bandwidth and trying to keep interventions as simple as possible. So I'll talk about improving health through behavioral science in a few different ways, through changing defaults, the use of financial incentives, and then through a variety of different ways of in doing health delivery system innovation, including food as medicine. So I'm going to start first with a slide, which is one of the more famous slides in behavioral economics, which depicts organ donor registration rates in different Western European countries. And in the left in blue are countries where you have to opt in to be listed as an organ donor. In the right in orange are countries where you were presumed to be an organ donor unless you explicitly opted out and said you didn't want to be. You can see here that these differences are pretty dramatic and really highlight the value of being intentional about which direction that switch is flipped. Do people need to opt in to sign up, or are they presumed to be signed up unless you flip the switch in the other direction? That, however, should not be thought of as a causal relationship because countries chose to be one or the other. They weren't randomly assigned. And this is much closer to causality, the work that was done by Bashirs, Choi et al. On retirement savings as the country shifted from pensions to 401k or 403b voluntary contribution plans. And you can see here, if you look at populations that were hired before automatic enrollment, the rate of people participating in a 401k starts pretty low, less than 20%, and it takes several years to get to 50%. Whereas if people start when they're hired, when enrollment in a 401k is automatic, it immediately jumps to 80%, and that tends to be pretty sticky. As we've thought about trying to apply these principles to healthcare, it's a little bit more complicated because we can't just default people into a smoking cessation program or a weight loss program, and then if they do nothing, we will presume success. The 401k example is a nice example of that, where inertia actually works in your favor once you've signed up, because if you do nothing, you're automatically saving money for your retirement after the initial sign up. But we've tested this and explored it in a number of settings. One is in the context of remote monitoring of blood sugars for patients with poorly controlled sugars, where the standard way in which we'd enroll patients would be to tell them about a program, free glycemic monitoring if you have poorly controlled sugars. A nurse will monitor your sugars and help intercede if needed. And when you offer this as an opt-in type program, you get 12.7% enrollment. We randomly offered some people what we called an opt-out framing, where we said, based on clinical criteria, we think you'll benefit from this program. Unless you tell us you don't want to be, we're going to assume you want to sign up. But so that this wasn't a Pyrrhic victory. To be considered signed up, you had to come in, meet with a nurse, and then take the glucometer home and send in at least one reading. We found that simply reframing this invitation tripled the rate at which people signed up for the programs. And what was particularly important to observe is hemoglobin A1Cs improved to a similar degree in both groups. So we didn't have a big difference in what was revealed post sign up. We had thought we might, that those who did not opt out would be less motivated than those who opted in. But we found that if you lower the barrier to participation, a lot of people will do well. We've also found this in a variety of other settings. This was an example of a study led by my colleague Siobhan Mehta, where they sent fecal occult blood tests to patients who said yes versus those who did not say no. And you can see here in this opt-out type framework, we got rates that were several times as high of colorectal cancer screening completion with opt-out defaults. I don't want you to think that this only applies to patients. This was an example with clinicians, where at Penn Medicine we had highly variable generic prescribing rates, and we were actually losing a lot of money because our insurer partners were in essence penalizing Penn Medicine for low generic prescribing rates. We realized that the default had not been, nobody had been intentional in thinking about the prescribing default. We switched it to generics, and you can see here overnight the generic prescribing rates jumped pretty dramatically, and in fact went to close to 90, 98, 99%. This was in fact quite sticky. We looked at this over a period of several years, and I think what it reveals is that clinicians weren't opposed to prescribing generics. It's just in the pre-intervention regime, nobody was going to look through a long list of medicines and figure out which were generics and take the time to prescribe them. But when we made that the path of least resistance, that was actually quite sustainable. And one of my colleagues actually appeared on Freakonomics to talk about this in a story that was headlined "How Penn Medicine Saved $32 million in 1 hour," because it was basically 1 hour of IT time that led to this sustained result over several years. I want to give an example of cardiac rehabilitation, which is another service which is highly effective, but in many cases it's underutilized. And in fact, at Penn, one of our cardiology fellows found a few years ago the referral rates were actually below 15%. Digging into this, as he learned about behavioral science, he realized there were a number of issues. One is that the patient had to opt in. The clinician needed to recognize the need for a referral, needed to sign a paper order, had to hand it to the patient. The patient had to select a setter, coordinate scheduling, transmit the referral. The referral needs to be transmitted. There are often challenges in terms of the location of the centers, their hours of operation, what insurance coverage they took. So in essence, there's a series of opt-in steps along the way. And what he realized was what he needed was a nudge pathway that, at least from the patient and clinician standpoint, would make it easy. So he redesigned this as an opt-out decision pathway. Patients were automatically identified and notified during rounds, and then rounds and the discharge process were restructured to facilitate this placement pre-discharge. So from the patient and clinician standpoint, it was made super easy, even though there were a number of steps behind the scenes that needed to be addressed. And it was quite striking how much this increased referral rates. You can see here in blue, the intervention group increased by 47 percentage points relative to the control group. So a pretty dramatic difference, but important recognition that sometimes nudges don't involve just flipping a switch. They involve thinking about the whole pathway of decisions and ways of making that easier for the end users. We did create, as Stacy mentioned, the first health system-based nudge unit in the world in 2016. There were a number of governmental nudge units around the world that had been created to improve the efficiency of government, but this was the first one that was developed within healthcare. And I think part of the appeal of these choice architecture interventions is they can support scaled application very nicely. They're often not rolled out as opt-in efficacy interventions, but effectiveness interventions where participation is very easy to attain at high levels. That can be done at low incremental cost. I mentioned the generic prescribing example, but it's important that these be seen as not overly heavy-handed and need to be carefully vetted with clinicians and other stakeholders prospectively, and sometimes gentler approaches are needed. An example of that was we did some work with CVS years ago where they had an automatic prescription refill program, which has some advantages, of course, in terms of convenience. And they offered it as an opt-in program. They didn't get the kind of sign-up rates they were hoping for. We asked them if they could switch it to an opt-out. They said, we can't switch it to an opt-out because every time we send out prescriptions, we have to charge people's credit cards. They'll be upset if they haven't explicitly authorized that. But we came up with an approach we called enhanced active choice. Press 1 if you prefer to refill your prescriptions by yourself each time, or press 2 if you prefer for us to do it for you automatically. And we really were just trying to highlight the salience in terms of convenience of having them do it for you versus do it for yourself. This roughly doubled the rate at which people sign up for the program and then was used by CVS as an on-ramp online, in person, on the phone, as a way of making it easier for people to sign up. Another example is health plan design itself, where you can think about the default design that many of us are part of is one in which there are deductibles and coinsurance. Makes it really difficult to estimate costs. So let's say, for example, you're trying to encourage patients to go to urgent care instead of the emergency room. In a world in which, or a plan in which you have deductibles and coinsurance, it's actually impossible to estimate that cost ex ante. But if you have copayments only, you can actually make it very clear. So in this plan, we came up with, working with our actuaries, a set of copayments, and it was $100 to go to urgent care, it was $400 to go to the emergency room. If you were admitted, the $400 was forgiven. And the beauty of this is that it was copayment only. It fit on a 2-page description, so we had very clear incentives to guide choices. And this plan has now been in effect at Humana for about 8 years. So I'm going to talk more about financial incentives and these are important because we've found that they are efficacious in lots of different contexts, which have been tested by our group and other groups. And we started this journey by looking at short-term cessation in a population of veteran smokers who are interested in smoking cessation. We randomized participants to either a program for free or the program plus incentives to attend each of 5 smoking cessation classes and short-term cessation. The rewards were given immediately, which is one of the key things, given immediate gratification in terms of design. And you can see, well, I should say, we found that enrollment rates were about 40% versus 20% in the intervention group versus the control group. Program completion rates 25 versus 12%. And we found a big difference in short-term cessation rates, but not long-term cessation rates. This led to the recognition that we needed to think more about designing the incentive system for longer-term cessation rates and also to think more about settings where there's more natural financial incentives to embed such programs, such as employer settings or health insurers. So we worked with General Electric on designing a program for their employees where employees were randomized to either usual care or usual care plus a package worth $750. These were unbundled from premiums to make them more visible. You would get $100 from completing a program, $250 for short-term cessation, $400 for longer term. And we found at 12 months a quit rate of 14.7 versus 5%, so that's quit rate ratio of 2.9. We turned off the incentives, and 6 months later, we still found a quit rate ratio of 2.6. I mentioned earlier that loss aversion is a very strong principle in behavioral economics. And so there was a lot of interest at this time in really thinking about whether incentives could be made stronger by having people contribute their own money or putting money up for people in advance and then having them lose money for not doing something as opposed to winning money for doing something. And we tested that among employees at CVS and follow-up where you could either get an incentive of $800 for quitting, or you would be asked in a so-called deposit contract to put down $150 of your own money, which we matched roughly 4-to-1 with $650, which you would lose if you did not quit smoking. And first, I want to contrast the orange and blue bars. You can see here at 12 months, we found very similar results to what we found among employees at General Electric, 3.4 versus 12.5%, so roughly a tripling of smoking cessation rates. But the deposit group did not do as well, so the quit rate at 12 months was 8.1%. And what was interesting about this is that among those who were willing to put deposits down, we had a phenomenal quit rate of 52%, but only 13.9% of participants in that study arm were willing to put money down. CVS was very intrigued by the 52% number, and so based on this, they decided to put in place a program that was called, sorry, we lost a zero here, 700 Good Reasons to Quit. And you were asked to put down $50, and that was matched 14-to-1, hence the name 700 Good Reasons to Quit. GE also implemented a program based on this study, but instead of using a reward, it became a stick. So they turned the reward for quitting smoking into a penalty for not quitting smoking, where you would pay higher premiums. I want to talk a bit about, I'm going to start talking a little bit about some other areas, including food. And one of the ones which I think is important to think about is recognizing that in some cases, when people have tried to incent healthy food consumption, that you don't magically see an increase in healthy food consumption by lowering the price. And this was an example of a study done by some investigators a few years ago, where they provided a 50% subsidy for increasing fruit and vegetable purchasing, but it only increased fruit and vegetable purchasing by 4.7%. And I think when we look more broadly at the USDA's GusNIP program, which provides incentives for fruits and vegetables, you can see there's a lot of money left on the table, which really surprised me when we first started looking into this and trying to understand how well the existing programs worked, that people left about a third of the money they were being offered for free food on the table and didn't spend it. And I think a lot of this has to do with what behavioral economists refer to as prospect theory, which is the graph on the right. And in essence, what this shows, and you can see this from the steeper slope of the line to the left of the 0 point, is that the disutility of a dollar lost is roughly twice the utility of a dollar gained. And it suggests that incentives framed as a foregone loss might be more effective than incentives framed as a gain. And I think discounts are often framed as a gain, but they could be framed as a foregone loss. And let me explain to you what I mean. So we did a study of this with physical activity, and we tested head-to-head, offering people in a 13-week RCT $1.40 a day for achieving a 7,000 daily step goal versus giving $42 at the beginning of a month where you'd lose $1.40 a day if you didn't meet the step goal. And you can see here, same amount of money, instead of going from 30 to 35%, you get from 30 to 45%. So we've been thinking about this in the context of food as medicine as well, where of course you can frame a discount, a subsidy that somebody gets each month as money you'll lose if you don't use it by the end of the month. And we've also found in the context of physical activity that this works very well. This was a recently published Be Active study where we looked at physical activity over a 12-month intervention period, a 6-month follow-up, and compared a gamification type approach, a loss frame financial incentive, the two together. The two together was the most effective, but you can see here that the loss framed incentive was pretty effective, as was gamification. That was based on a previous study that was actually the first intervention study done in the Framingham cohort, where we built a lot of these behavioral economic concepts into a gamification solution where people were grouped in families and we used social accountability and variable reinforcement where every day you'd be notified, one of the family members would be notified that based on their step count, their family either had won or lost points. And this gamification approach, even though it didn't cost any money, led to about 52% of people meeting their step goals compared to about 30% in the control. So a few key take-home points on incentives. One is that small incentives can work. A lot of the design features are quite important. We need immediate feedback. We can use behavioral economic constructs to increase incentive effectiveness. Incentives tend to work better, of course, if people understand them and they're salient. So it's really important to always think about how to make the designs as simple as possible. And we have found over the years that testing these programs in settings where they can scale does a lot to increase translation into practice. So I'm going to switch gears and talk a little bit about health delivery system innovation, including food as medicine. And first, I'm going to talk about the Penn Medicine ASCVD Risk Reduction Initiative, where we've been focusing on lowering risk from atherosclerotic cardiovascular disease. And in essence, the way we've thought about this is as an innovation process where we started by thinking about initial pilot studies we felt we needed to do. This was all part of our CTSA, I should say, over a 5-year period from 2021 to 26, where we started with initial pilot studies to validate or refute assumptions, and then did a number of these shorter term studies in parallel to look at efficacy and think about what we could do to improve and de-risk the definitive trial to follow. Then the definitive trial is being run now, and then we're looking at broader implementation and dissemination. So we're trying to move from a system in which risk reduction was fairly reactive, is based on visits, and reliant on very limited clinician resources to something more proactive, scalable, where we could have a program that would be more widely used. And the pilots were selected based on 4 different criteria: modifiable risk factors in terms of blood pressure and LDL cholesterol, high risk populations, clinician patient behavior change opportunities, and strong enough nudges to be impactful. A lot of this was related in terms of the work with clinician navigators on cohort studies done at the Brigham by Sirica et al. But we had a number of these 10 randomized trials, 6 quality improvement studies, 4 rapid cycle tests involving a lot of patients and a lot of qualitative work to try to learn as much as we could from this preliminary phase. And there's really two sets of pilot studies, which I'll briefly summarize. One was a set of pilots which were quite successful and where we learned elements of program design which we thought could be useful parts of the main intervention. And the short summary of this is that those interventions which were asynchronous, which involve remote monitoring and centralized prescribing, worked pretty well. So you can see here, for example, in the top left, the super lipid trial led by Alex Faneroff, we had an odds ratio of 6.79 in increasing appropriate statin prescribing using asynchronous bulk referral orders to a pharmacy. and then central pharmacists did the orders. In contrast, we had a lot of pilots where we had very modest effects or effects that were really small. And I'll contrast the trial I just mentioned with the superlipid trial, also run by Alex Vanneroff, which was a visit-based nudge. And you can see there that the odds ratio was 1.40. And in essence, a short summary of a lot of different studies was that efforts to change individual clinician behavior in visit-based models were not very effective. And I think a lot of that has to do with the fact that there is just too much loaded on clinicians already, and there's too much loaded on each visit. And so doing this outside of visits and having someone else do it on behalf of the primary care clinician really was the way to go. And you can see that from these other studies here too, where there's modest effects of various ways of nudging clinicians, giving them feedback on how they're doing compared to their peers, and then setting up default blood pressure visits. Each of these had fairly modest effects, so we do not include any of these in what we did for the main Penn Medicine Healthy Heart trial. So we now have a trial that's underway. We have fully enrolled with 2,420 patients, age 35 to 80, elevated risk of ASCVD, blood pressure LDL-C not well controlled, and we're running this in 33 primary care practices in West Southwest Philly and Lancaster County. We're looking at effectiveness of a solution which is designed to offload work from primary care clinicians focused on primary endpoints of systolic blood pressure and LDL-C, and using a centralized team of non-clinician navigators and advanced practice providers, a lot of remote monitoring and bidirectional text messaging, and then we're using behavioral science engagement strategies. We have 4 different modules that are part of this. Principally, we focus on blood pressure and lipid management, but we also do some on nutrition and smoking cessation in a phased approach. And then I want to share a bit about healthcare by food. As Stacy mentioned, I'm the scientific lead of AHA's national initiative. And this has been getting a lot of traction because we all know that food is central to health outcomes and affects many different organ systems in the body. Yet Americans don't have very healthy diets. And there are lots of statistics that bear this out. 1 in 10 meeting recommended fruit and vegetable intake, 2% meeting whole grains targets, more than 9 in 10 having excess sodium intake, and Americans consume more than 60 pounds of sugar each year. So lots of room for improvement. And we've been focused on trying to think about how to address the underlying challenge of affordability. So 77% of Americans, based on a recent national survey by AHA, Deloitte, and Research America, say they would like to have healthier diets, but identify the top barrier to eating a healthy diet as the cost of healthy food. And sadly, more than half indicated that it often happens that children are eating cheap, unhealthy food so their families can pay the rent, or that seniors often have to choose between paying for prescription drugs or paying for food. So when we talk about food as medicine programs, we're not talking about the general population writ large. It's really focusing on the subset of the population that's really struggling to have access to healthier food. And I think it's safe to say the health system hasn't tried systematically to increase healthy food access for high-risk people. And that's, in essence, a big part of what we summarized in this recent Food is Medicine Presidential Advisory, where we take stock of the evidence in the field, where the gaps are, and we talk about some of the strategy for the initiative. I'm just going to highlight a few points in terms of how we've thought about this. One is the importance of meeting people where they are with human-centered design. So the double diamond on the left is a construct that's often used by human-centered designers, where you focus on contextual inquiry and discovery, crisp problem definition, deliberate divergence, where you test different models, and then validation of potential solutions with rapid cycle experiments. In the middle, we have the prospect theory graph to highlight the importance of bringing behavioral science into the mix and thinking about how to design programs with behavior change based concepts in mind. And then finally, On the right is the importance of having rigor in testing, where there have been very few randomized trials done in this field previously. And we now, I think there have been a total of 14 trials that have been done prior to the start of AHA's Healthcare by Food initiative. We now have 23 trials in the field. So here's where we are in terms of thinking about our strategy, and you'll see some parallelism to how we've thought about the Penn Medicine Healthy Heart initiative and trying to de-risk larger scale trials to follow. So in essence, we're making a lot of small bets before making big bets. We're now in the stage of finishing platform design and short-term pilots. We're moving into component testing and intervention refinement, and then on to some larger scale trials where we're looking to work all along with public and private payers and health systems to extend coverage. We have 23 randomized trials and 2 secondary studies that are being done around the country. We have also now started working with several state Medicaid programs and some commercial insurers to evaluate what they're doing. We are also supporting our research teams with what groups do better than individuals. So part of this was setting up a cooperative studies framework where each of the funded studies gets support from human-centered designers, behavioral scientists, cost effectiveness experts, statisticians, and experts in community engagement and implementation science. And then we have several task forces that are focused on various other elements where it made sense not to have each individual team figuring things out for themselves, but really trying to help make the collective more effective than it otherwise would be. Our focus is on the gaps in evidence for coverage determination. So we have some existing evidence from WIC, from medically tailored meals, products, prescriptions, medically tailored groceries. But if you think about what a clinician would need to know to prescribe benefits, what an insurer would need to know if they wanted to cover benefits, lots of open questions about intensity, duration, delivery. How do you initially engage people at very high rates? How do you help people change their behavior and form habits? What's the role of coaching and other supports? And importantly, we want to do as much testing where we can of program effectiveness in settings where the programs can be scaled, and then the cost effectiveness, of course, will be an important consideration in terms of coverage. And then finally, every system is perfectly designed to get the results it gets. And if we want different results, we obviously need to think about how to change the system. So we've had some system design workshops and architects thinking about this and thinking about how we can work together across different parts of the healthcare system to try to get different results. We have a lot of different community-based organization collaborators, a lot of healthcare and corporate collaborators as well. And it's been a terrific start to the initiative. We have about 250 people who are involved in the initiative, either as researchers or as implementation partners or as collaborators at companies or community-based organizations. And then finally, I wanted to close, since this is a medical audience, by talking about a very personal experience I had as a cardiac arrest survivor. So in 2021, in July, I was training for a half Ironman triathlon with my daughter Anna on the bottom left. And everything was going great, felt well, had no symptoms, and as far as I knew, was pretty healthy. And then one day at a restaurant, my heart stopped. And fortunately, I was with two of my another daughter's coaches. One was the guy in the blue shirt here, John White, who quickly recognized that I didn't have a pulse. And John started CPR, and the other coach, Gina Stoker, called 911. So here you can see the train of what happened. And it all happened, fortunately for me, very quickly. So you can see here, EMS received the call pretty quickly. EMS was dispatched. It was very interesting looking through these records because I could see that EMS was dispatched within 12 seconds of the call, and they were on the scene within 5 minutes. Then they had to use the defibrillator 3 times, epinephrine, amiodarone. I regained my pulse, but it was about 14 minutes without a pulse. And then they left the scene with me in the ambulance. But then fortunately, I was near the University of Cincinnati ED, which is a major medical center. The cath team was on the way. I was intubated, taken to a cath lab. And you can see when you think about the AHA chain of survival, if any one of these links is missing, unfortunately, you're unlikely to make it. And 90% of people, as you probably know, who have out-of-hospital cardiac arrest don't survive. So you have to be pretty lucky to have all these elements in place. But part of why I bring this up, and I try to bring this up when I give talks to medical audiences, is to really just highlight the importance of each of these chains, the importance of bystander CPR, the importance of defibrillators, and the importance of awareness, where we all need to recognize that each of these links in the chain of survival is just absolutely critical. So in this interview I did with Donald Lloyd-Jones at AHA Scientific Sessions that fall, highlighted the importance of increasing CPR training and AED presence. There's, of course, a lot we can do to optimize modifiable risk for our patients. We could probably reduce the rate of cardiac events by 70% or something like that if we could optimize people's smoking habits, eating, et cetera. We also could do better at predicting future cardiovascular events. There's a lot of variability in survival rates across the country. Kings County, Seattle, survival rate out of hospital cardiac arrest probably about 25%, and in some other parts of the country it's 3%. So there's a lot that could be learned there. And part of that is through the National CARES Registry, which is the main body that does quality improvement activities around the country and collects data, but only about half the country, a little more than half the country participates. And their funding has been from a variety of organizations, including the AHA. And then 2 years ago, they got funding from the CDC, but now that funding is at risk. So it's all very fragile. So when you think about what's at stake for the 400,000 people a year in the US who have sudden cardiac arrest, we need a better system for conducting quality improvement and trying to further improve survival rates. So with that, I'm going to stop there and thank you very much for listening and look forward to the Q&A.
Kevin, thank you. Rosanna, I'm on, I hope. Good,
You
good.
are.
There've been endless questions. So thank you. Thank you firstly for sharing your story. I was privileged to be in the audience with that conversation with DLJ, and it was really quite inspiring. The questions are coming from clinicians, scientists, as well as some of our administrative staff. Can I ask you first to go back a little bit and expand on what nudge theory is? For those who haven't read the book by Sunstein and Thaler, you must. So maybe just a little bit more background for those on the call who don't know much about it.
Sure. And sorry, I didn't explain that as well as I might have. So the idea behind a nudge is that we can change the nature of the environment in which people make choices, where, for example, we can change the order in which items appear on a list. We can change how food is arranged in a cafeteria. So, for example, if we use a cafeteria, somebody needs to decide where do you put which food items. And research has indicated that the food that's in the middle of the cafeteria tends to be chosen most. So you could put the healthy food there, you could put the most profitable food there, you could do it at random, but no escaping that somebody needs to make a decision. And the key thing about nudges is that you're not actually taking choices off the menu. So for example, in the context of cafeteria, you would still have the burgers and supersized fries. You just put them in the back corner instead of in the middle, but you're not taking them off the menu. And that's an important principle because we're trying to make it easier for people to make the decisions we would like them to make, but we're not regulating, we're not mandating that they do so. If they have strong preferences, they can still have the supersized burger and fries.
Perfect. Thank you. From one of our child obesity clinicians, What about prevention's behaviors that require skill building and active practicing of skills? I research early child obesity prevention. This often seems to be a barrier to success for low touch interventions.
Yeah, I think that's an important question. So one of the questions that a lot of people are grappling with is what combination of skill building, education, making choices easier, incentives is really optimal. And it's really an empirical question because it clearly in many settings is not enough to just give people information. It's also not enough in many settings to try to nudge people to do things if they don't really understand what it is that they should be trying to do. So really thinking about the combination of some sort of light touch skill building, coaching, and where that fits is important in most of these contexts.
Rick, thank you. Any concerns from an ethical standpoint about opt-out processes, informed consent, issues like that?
Yeah, it's a very good question, and I would say it all depends on context. So, for example, if we're talking about trying to, let's say, do colorectal cancer screening at a higher rate, I don't think ethicists would have any problem with sending people fecal occult blood test kits that they could choose whether to use or not. And there's really no when the issue I think is really weighing benefit versus risk. On the other hand, if let's say you were conducting a clinical trial and there's significant risk to taking an experimental medication which could cause liver failure, it'd be totally inappropriate to use an opt-out mechanism. There, I think there needs to be an opt-in process with full accounting of risks and benefits. So it's really, I think stepping back, a question of trying to weigh benefit versus risk. And in most of the contexts in which people are using opt-outs, it's in settings where the benefits are dramatically greater than the risks.
Wonderful, thank you. From our Director of Cardiovascular Prevention, we as a health system are pivoting to EPIC. Any simple suggestions for effective nudges, best practice alerts, decision making? We know physicians, as you said, are overwhelmed with the information and the opportunities to miss important things with regard to risk prevention. Any suggestions?
Yeah, I have a few suggestions. So we have, broadly speaking, found that best practice alerts don't work that well. And maybe in the old days when there were very few of them, they worked better. But now that there's so many, I think there's a real issue in terms of diminishing marginal returns and even negative returns because people are so overwhelmed. So we tend to recommend not using them. I think another key principle when you think about defaults and opt-in and opt-out is making sure you stick very closely to the evidence. And if there are gaps in what people are doing relative to what the evidence strongly suggests, those are good opportunities to think about whether it would make sense to change some of the defaults from opt-ins to opt-outs. There's also, I think, another possibility, which is in essence what we're testing with the Penn Medicine Healthy Heart Program, is selectively, does it make sense to actually bypass clinicians with, if there's things that are very algorithmic, where the benefits are much greater than the risk, does it make sense to have everything run through the primary care clinician when it could actually be done by somebody else on their behalf and be much easier for them. And I will clarify that we don't do that without the consent and acknowledgement of the clinician. So for example, in Penn Medicine Healthy Heart, each clinician gets a list of patients who we are thinking of enrolling in the program based on the fact that they have poorly controlled blood pressure, cholesterol, and the clinician can either opt out altogether, or they can opt out specific patients. So I think that's important too. You don't want people to feel like you're commandeering what happens with their patients without them being aware that that's happening.
And to follow up, what has been the physician's feeling about that approach in the HALT
I
program?
think very positive, perhaps revealed by the fact that about 90% of patients are not opted out. So the percentage who opt out, or the percentage of potentially eligible patients who are opted out is probably about 8%. So it's pretty low.
Fabulous. One of my colleagues asked, is there any concern about incentivizing individual physicians based on patient outcomes or actions? Would there be the concern that patients who are healthier or more compliant, adherent, would potentially be chosen by the clinicians just to create incentives that don't really improve care?
Yes, I think that's an important thought, and it's particularly a potential problem if you incent based on patient outcomes as opposed to improvement in patient outcomes over time. So, for example, you know, I think you're right that if you have a strong incentive and it's tied to, let's just say, having well-controlled blood pressure, you can imagine, um, maybe not intentionally, but at least inadvertently, clinicians might prefer patients who have well-controlled blood pressure and avoid those with really challenging to control blood pressure. So if you were to have an incentive program, I would suggest it be based on some combination of process and outcomes, or weigh improvement, as opposed to just attainment of outcomes alone, because you don't want those paradoxical effects.
Thank you. Any suggestions on the financial model to justify pharmacy, APP support as we move the needle for implementation of lifestyle and medical therapy? Again, from one of my cardiovascular colleagues.
Yeah, that's something we've been thinking a lot about. There are various, one of the funny paradoxes is we had a financial analysis done by one of our MBA students along with the head of our primary care service line. And it came to this what we thought at the time was a paradoxical conclusion, which is that it was very hard for a remote monitoring blood pressure type program to break even using value-based financing alone, because we don't have enough different incentive dollars in play in terms of value-based incentives. And there's all sorts of challenges with attribution because there are lots of other population health programs, each of which, arguably could say we had something to do with that too. And the interesting irony was that it is possible to actually more than break even using fee for service if you maximize what you're able to do in terms of various codes. The most challenging though is the remote patient monitoring codes, where you have to, as you may know, have a patient check their blood pressure at least 16 times a month. There's no evidence, Dr. Rosen, that I know of that says 16 is highly evidence-based and 15 is not. But that is what CMS has stipulated. So that's a big hurdle, and we're trying to figure out how to either um, captures revenue from some combination of that and billing for time by advanced practice providers. We're also trying to figure out, are there ways to use AI or other technologies to make the interventions much less expensive? And that could be a path forward.
Two quick last questions. I would be remiss if I didn't ask if there were any differences between the results from men and women in some of your ongoing trials.
Generally, I would say no. We have found, well, I should add the caveat, we are not generally powered to look at differences in subgroups in general. So when I say we don't observe differences between men and women, that may be part of the reason why, but we don't generally observe any differences between men and women.
Great. And one last question about Northwell Health. We have wellness credits for employees that participate in our health plans. And the credits have financial incentives, but the bar is quite low. We incentivize for a screening test or watching an educational video. Would it be ethical or effective to have incentives that were based on setting and meeting personal health goals, blood pressure control, A1C drop, physical activity? Do large insurers have an impact when they're having sort of a higher bar for the financial incentive?
They can, but there are a lot of incentive programs out there that are not very well designed.
Mhm.
And there's a couple of common mistakes. One is that a lot of times once these programs start, everyone has a lot of ideas on what should be included, and you end up incenting 45 things, each just a little bit. And tiny little incentives don't have any impact. Incentive programs that are very diffuse don't work because people don't know what to focus on. So if you were to do it, I would say focus on a few key things that are important, like quitting smoking, getting your blood pressure under control, being more physically active, things that can also be measured reliably, because that's another common challenge.
Perfect. I think we're hitting the top of the hour. Dr. Volpp, this was fabulous. Thank you. There are plenty more questions, but maybe we'll text you just a few. I want
Sure.
to thank you for joining us from Philadelphia and for everyone who attended today. Just a reminder, the chat box has the link for the CME credit. We look forward to seeing you all for our next Mary and Richard Slone Grand Rounds on September 30th with our guest speaker, Dr. Wanda Nicholson from the U.S. Preventive Services Task Force and the Milken Institute School of Public Health. Kevin, thank you so much again for joining us today.
Thank you, Stacy. Thank you, everybody.